I'm Andy Dwyer, and on behalf of the Patient Navigator Training Collaborative and our Alliance of Community Health Workers, Navigators, and Promotores de Salud, we're super excited in the final webinar series to talk a bit about the role and function of navigation and community health work for mental and behavioral health interventions in the work. So we're super excited to have actually a panel that are both urban and rural, providing some perspective of thinking about navigators and community health workers really delivering intervention services and resources to our communities based on the mental and behavioral health resources that are available. So we will go ahead and get started. Erin, why don't I punt to you to talk a little bit about the technical component, and then we'll bring up information about the series, and then I will hand off to our presenters for today after we do some introductions. So Erin?
Hi everyone, I'll just point out a few things for you. In your bottom left-hand corner of your Zoom screen, you can find some audio options if you need to increase the sound or play with it, your speaker or anything like that. You can find it there. We will have plenty of time for Q&A and discussion. So in the middle of your toolbar, you can find the Q&A button and just click on that, and you'll be able to enter in a question or a comment, and we'll be able to get to that later in our presentation.
Okie doke, very good. So Erin, do you want to bring up our series and we'll talk a little bit about what we're doing today, and then ultimately what we have saved on our website as well. I'd love to give also a huge shout out to the Colorado Health Foundation for the resources to conduct this series of webinars around the mental and behavioral health series. We did start at the top of May, giving some statistics and information about the state of the state, the resources that are available in Colorado from our friends at the Colorado Department of Public Health and Environment, as well as the Colorado Behavioral Health Council. Gave some ideas and some also some just general snapshot of what's happening in the policy and advocacy front, as well as some of the legislation and possible resources that will be coming through to Colorado. We had an opportunity also to hear about some of the resources such as mental health first aid, a number of the interventions that are being offered through our various partners in terms of helping provide training and support for the role of community health worker and navigator in team-based care for mental and behavioral health. As well as hearing a bit about the different sort of interventions that have been implemented that might have started with a more chronic disease approach, but have adapted and engaged with mental and behavioral health as a component. So we heard from some of our statewide partners, as well as a health psychologist, about thinking about beyond mental health screening and how do we really think about engagement of patients from sort of a psychosocial and mental and behavioral health theory approach. So we're really excited about that work. So for all of those modules that have been recorded and all of our presenters who provided the information and resources, that is saved on the Patient Navigator Training Collaborative site. So what Erin is scrolling through right now gives the background objectives, as well as the video offerings that were recorded from that period of time. So I think to date, we've already had, I think, 8 presenters who've been really engaged in this work. And for today, we want to, again, really thinking of navigators at the core, and navigators and community health workers really, again, thinking about the urban and rural settings, and our panelists who are from those different backgrounds. We'll talk a little bit about how they have really moved forward with this type of approach with CHWs and PNs being at the helm of delivering interventions, resources to their communities. So we do have an opportunity to have Kristen, who's the Director of Navigation and Resources from the Jefferson Center, from the mental health, the Jefferson Center for Mental Health. I can't talk today. And then we'll have Jackie and then Kaysie Schmidt will be talking about their work also in the Otero and the Lamar. Oh goodness, I'm thinking Lamar. I know Lamar's County. Don't tell me. Jackie, you might have to jump in. Otero and
Flowers,
good gosh.
Yeah.
So Cheyenne County is where I'm from, and then it goes Kiowa, then it goes per hours, and then you go over to Otero. So my bad with Baca and everything else coming in between. So kicking myself for being a Colorado native right now and blanking on that. But I think it's really awesome that we will have an opportunity to hear from an urban approach as well as what's happening in eastern rural Colorado in terms of these specific types of approaches and interventions. I'm going to have each one of our panelists share a little bit further about their background, also their role in the work, and also a little bit more about their setting. And ladies, thanks a million for being on today. We're going to start with Kristen as she speaks about the work that they're doing. And I would just love for you all to also share any lessons learned along the way, anything that you would share with anybody who's really thinking about this sort of approach in their work moving ahead. So Kristen, we'll start with you, and then we will go with Jackie and Kaysie. And I just want to make sure, Erin, I'm not forgetting anything else before we move on. Is that correct?
I think we're good to go.
All right, ladies. So thank you so much. We've got over 25, 30 folks on the line. So we'll go ahead and hand it over to you, Kristen. And Kristen, I think you might be on mute, but we can see you.
Thanks. I was doing two things at once, so don't do that. All right.
Very good.
Lessons learned. All right. Well, thank you so much for having me here today. So Jefferson Center, I'll go into a little bit more details about who we are and what we do and where we serve. But for me personally, so I've worked at the center since 2006, and that was actually the beginning of our navigation department. I was one of the first 4 navigators hired at Jefferson Center. So if you want lessons learned and journeys along the way, I've got stories for all of them. We started with a pager and binders of resources. And as you'll see, as I kind of go through, we've come a long way from that. So definitely, I think in terms of starting up any program, but especially something like navigation, which can look so different in so many different settings, just to give yourself the grace and the knowledge that you will make mistakes. It will be challenging, but the goal is to help people, and you'll find your way. So I've been the director of navigation since 2015, and the department is bigger than kind of the resource navigation piece. We have housing team, we have benefits specialists, but what I'll be focusing on today is really our central navigation team. So this is our group of folks who are providing immediate, as needed clinical assistance regarding Jefferson Center program eligibility, problem solving, benefits, resource referrals for our clients. We also see our consumers as clients, staff, and community members. So really a one-stop shop for you need help, how can we help you? So Jefferson Center is a community mental health center established in 1958. And we do serve primarily Jefferson counties, so in the Denver metro area, and then also Gilpin and Clear Creek. So do go up to the Eisenhower Tunnel up in the mountains there. And I always point out, though, that there's not the same residency requirements that I think there once was with community mental health centers. So we serve folks from all over the state with a lot of different services, and one of those are our navigation team. We can serve anybody regardless of where they're living. So Jefferson Center serves 34,000 individuals annually. We have 650 employees, 23 clinical locations, and that does not include all of our community settings like schools, jails, nursing homes. We go into people's homes or in homeless shelters. So really, like, Jefferson Center, we try to be everywhere. We serve everyone, kiddos, families, seniors, veterans, and offer the whole array of community behavioral health services, including detox, walk-in center, crisis. So basically, we're a really big system. And then you start to think about, we're a really big system within a lot of really big, complicated systems. We've got human services, criminal justice, housing, children, youth, and families, social security. This is a lot for anybody to navigate. And so that was really where this idea in 2006 came out, was because of the complexity of our system and other health and helping systems, the folks who are most in need are falling through the cracks because they can't navigate, or they don't know where to go, or they don't know where to start. So navigation was developed to provide that personal connection for all consumers to assist them on their recovery journey. And so we use principles of a recovery-oriented system and client-centered services, and really being that single entry point for immediate as needed assistance to clients and accessing, linking, and bridging needed services for the best use of resources in a managed care environment. So how do we do more with less, which especially right now as budgets are getting tighter is very, very timely. So the program goal was to be a link for consumers to all services, internal or external. And what we found pretty quickly is folks liked us. Staff liked it, clients liked it. They liked having a place to go, to call, to get a live person on the phone. I can't tell you how many clients we had call and be surprised when somebody actually answered, because they're used to being in these other big systems, which are a mass of voicemails that may or may not get returned and all those good things. So in 2010, we were awarded the Golden Light Bulb through CBHC, through the Colorado Behavioral Healthcare Council, which was a really nice opportunity for us to get to share kind of our vision and what we do with a broader group of folks. So as I'm sure has been talked about and you all are aware of, but looking at Maslow's hierarchy and how we integrate, do this whole health integration, navigation at Jefferson Center, we're helping clients meet those basic needs. And with the knowledge that if we can reduce those barriers to treatment, if we can get them housing, if we can get them transportation, we can allow the rest of the treatment team to focus on more clinical issues and allow those clients to move up the hierarchy and to address whatever they're needing to address. If it's depression or substance use, those are things you just can't do if you're homeless or wondering where your next meal is going to come from. So how we do that, to support resilience and recovery, the Navigators engage clients in a helpful and respectful manner with a customer service orientation. And we promote a case management model of doing with consumers rather than doing for consumers. And this was new in 2006. It was very much case management with those high intensive clients who you sat with, you took to the grocery store, you did these things. And we came in and said, hey, we're gonna just kind of teach people what to do. And a lot of the initial feedback was like, whoa, what do you mean you're not gonna fill out this application for them or, drive them to look in an apartment? And there are certain people who need that level of care, but the majority of folks that we interact with, we can teach them how to do it. And so we do that in really creative ways. We do a lot of motivational interviewing and have developed a specific motivational interviewing training for our navigators that uses real world examples. We've really tailored it to them. And then we have this customer service orientation first and foremost. So, our understanding and our experience is that engagement is not some weird out there concept. Engagement is giving people what they want it. And if folks have a positive experience, they're going to be more likely to re-engage. And so we really always strive in all levels of our team, and that has to be supported from, boots on the ground all the way up through, management, senior management, wherever you go, just really that customer service focus and orientation. So the team right now, as it's comprised of, we have 7 master's level clinicians, including 1 coordinator and 2 bachelor's level case management. And this is going to look really different in different settings, in different teams, and different responsibilities. For this navigation team, they're doing kind of the traditional case management linking. We are also now the point of entry for all of new clients accessing Jefferson Center. So that's been a really exciting development over the past couple of years, where we've been able to be truly that one-stop shop for clients who are calling saying, I need help. And whether that help is mental health services, whether that help is resources, housing, benefits, whatever that is, our staff are able to meet that need. And so we can do pre-screenings with clients, we can get them in for an intake, we can refer them out if we're not the best fit for them, or if we don't take that insurance, or whatever that is, we can be that kind of warm handoff. How we adjust that team size is kind of threefold. So we look a lot at our phone. We do a lot of data and tracking of phone calls and of our answer rates. So as I've mentioned, the majority of our services are provided over the phone. And so the management team is always looking at what's our phone volume and then what's our answer rate? How many are we getting to live? And that has ebbed and flowed over time. We've had times where it's been as high as 90%, 95. We've had times of short staffing where that has plummeted. And so that's kind of been one of our main gauges for how we can do that. And we try to maintain over an 80–85% answer rate at all times. We also look at locations and kind of where we should house our clinicians or our navigation team within the center. So are there places where we have more walk-in services? Are we getting more foot traffic? So we can track that through our electronic medical record and see, okay, this person housed at this location is only getting 3 walk-ins a week, but this other location is having trouble meeting the demand. Let's move them over there. You know, so really using a lot of data to meet those needs. And then also, you know, kind of the third part is really looking at what are all the duties that they're being tasked with. So when we added on this additional part of being that coordinated entry for the center and doing pre-screenings, we had to add additional staff with them. So how we do what we do, again, phone, very important, very immediate, very in the moment. Email, we have a client portal that we respond to, so clients can reach out to us that way. And I mentioned walk-ins, and that was something that in the beginning of navigation, we didn't get many walk-ins, and over time that has increased pretty substantially. And, you know, we've really found that for urgent cases, so homelessness, financial assistance, we manage some grants. So folks who are in need of that immediate, my energy is gonna get turned off, how do I get Energy Outreach Colorado? Housing, and staff and clients have really identified that as being an effective way of meeting the needs of our clients who maybe can't reach us over phone or in their office right now and need help. And so that's been great. And that's kind of another way where we've really been able to free up clinician time to spend, you know, their whole 50-minute session on mental health. Something comes up in terms of basic needs or case management, they're able to say, walk down the hall and talk to navigation or give them a call or let's email them. And they have a place to kind of do a warm handoff for the client, and they know that they're going to get good care with us. So these are the different services that this team does. Benefits assistance is a big one. We do have 2 benefit specialists separately and kind of their own little team, which delve really into the disability and helping advocate for clients through some of these very complex systems. But we do partner with the county, and we have an on-site Jefferson County Human Services representative, so we can help folks very quickly get on Medicaid, food assistance, you know, TANF, all those kind of in the moment human services, we can do that very quickly. And then internal referrals, as I mentioned, we're experts in our system, which is very complex. So what groups are going on? Who does that person need to go to if they want a higher level of care? What if they don't like their prescriber? You know, we can kind of help them navigate throughout our system. And then external referrals, we use OneSheet. So that's what we call our resource sheets. And these have been developed over time, and I'll show you an example here in a second. But this is a website that anybody can access. So, and I'll be sharing my slides so you have another opportunity to look at this. But other agencies and organizations have linked to this. No need to recreate the wheel, but this is our tool that we've developed over all these years for how to do that effective health communication. This might be a little small, and I apologize, but as you can see from this one, this is a timely example of one that we just made. It's not just a list of resources. We give tips, we give tricks, we talk about how to do this, we talk about what to bring, we talk about how, what to expect. So when you show up, sometimes they make you wait in a line. Like, we try to include every detail that we would find helpful. And these are resources for clients, but they're also how our staff are trained in what these external resources are. We have over 150 of these resource sheets. Nobody could remember all those resources that exist, because we are fortunate to be in a metro area where we have Denver right next to us, we have Boulder down the road, so we have a lot of resources around us. And some of these, you know, we call them one sheets, but they can get up to like 10, 15 pages long. So we are tracking our resources that we can refer our clients to, and then when we're on the phone with somebody or when we're interacting, we're tailoring them. We're saying, start with these 3. And that's where that motivational interviewing comes in so handy, because if a client calls and says, I'm in crisis, I need help, giving them a 10-page list of resources is probably not going to be super helpful. But if we say, call these 2 numbers, let's start here, call me back, we're going to see how that goes, we're going to work through this together, it's a very different message. And, you know, we do have that kind of back and forth relationship, or we'll email them these resource sheets and they'll email us back. And you can see at the top of all of our resource sheets, we always encourage this to be a partnership of information sharing. So if they've called someplace and they didn't find what we sent helpful, or if that phone number has changed, or that agency is now out of business, which happens, let us know, because we want to keep these up to date. We do that with staff. We get feedback all the time, new resources. And then you can see we track how often we update these and try to update them at least annually, if not more often. So of course there are some challenges and lessons learned. I think, you know, the biggest challenge obviously that we face is one of funding. So we have a reactive healthcare system in the United States that likes to pay for things once they're a problem. We get, you know, you're sick, you get meds. You have a mental health diagnosis, your insurance company will pay for therapy. Not a whole lot of money in preventative care. And that's really what we're doing. We're trying to prevent that client from becoming homeless and then all the costs that incur with that. We're helping them get into services, maybe even before they're in a mental health, they even have a mental health diagnosis, and you know, are just wanting to talk to somebody or get some education, and we're providing that. So as many of you know, Medicaid is one of the primary funders that even has service funding for case management and preventative care. And so that's really what we're focused on. We're not turning anyone away for any other services. So folks with private insurance are not getting turned away. They can access us in the same way as anybody else. But that takes a commitment from the agency and really kind of being committed to that population health and prevention and understanding that this is preventing higher levels of services. This is allowing you know, individual therapists to be more productive and bill at higher rates and, you know, all that kind of stuff. So there's a lot of systems pieces that are going into play here, and having access to dealing with a reactive payment model to try to do proactive treatment is always exciting. And so yeah, really looking at what is that lower reimbursement rate, and then that requires the commitment of your agency and your organization to understand population health and prevention. So we're preventing that higher level of care. We're preventing that crisis like homelessness that leads to more costs and higher costs of service. Only Medicaid reimburses, or, you know, there's a couple of funding for case management and prevention services, but there's not a lot. And so we don't want to turn away anyone with private insurance, and we don't, but we know that we don't get paid for them. So we have to balance those out in creative ways. And then for anyone who has billed Medicaid for case management, it's complicated, and we have a lot of detailed training documentation, training and documentation guidelines that we're helping our team to understand how to do that. So just kind of to wrap up, in the navigation team, we promote recovery through engagement and empowerment. Whether it's scheduling an appointment, maintaining housing, applying for disability, addressing clients' depression, or connecting to resources such as transportation, clients receive assistance through navigation. So internal and external staff needing professional collaboration, case management assistance with clients, information about housing vouchers or transitioning to a different level of care within Jefferson Center interact daily. And we believe this is an important and valuable service. So I'm excited to hear the questions and hopefully provide some more answers. And thank you so much.
Great. This was a remarkably good presentation. Thank you so much. Kristen, a couple questions. As you were just concluding with discussion about payment and reimbursement, you did talk about Medicaid being one of those one of the opportunities to reimburse, and then for privately insured as well. Are you able with lay health navigators to reimburse, or only for folks who are doing this work in a professional licensed manner?
So we can do it with bachelor's level. There are certain codes that bachelor's level clinicians can bill under. So that's why we can do bachelor's and then also master's level clinicians. So they do have to be credentialed with Medicaid. And then again, there's kind of different billing codes that we can use. And I'm always happy if anyone wants to shoot me an email and ask me for our coding training cheat sheets. I'm always happy to share those if that would be helpful.
Awesome. Kristen, in the future, and I don't know if you and Kaysie and Jackie might be, but I do think that might be something that would be, would you think that would be something that would be another webinar to focus on how that works, or are the tip sheets alone helpful in guiding folks around the billing component? Is it pretty nuanced or no?
It depends on how detailed you want to get. So it's nuanced in terms of like specifically around case management. So the requirements to bill a case management code are pretty specific. And I think that that's kind of where, depending on people's comfort level with the coding manual, that's where we've really kind of broken it down into those more like, here's an example of when you would use this code. Here's some verbiage to use. You have to say resource and referral. You have to do this and this. So it's fairly detailed in terms of like who can do what, and you know, if it's a bachelor's or a master's, that's a little more straightforward.
All right.
Yeah.
Great. And then Kristen, let me ask as well, because I think this is delightful to see that you do have the opportunity to bill and to do this sort of work. Let me just ask for training. I think you used and talked a little bit about folks engaging in MI techniques. What kind of training have you provided your folks who are working and serving in these navigator positions?
Yeah, so the majority of them are master's level clinicians. So they have received a lot of training, and we're really just kind of training them in our model and what this looks like. Obviously, this is a great fit for social workers like myself who you know, kind of have the systems modeled to begin with. And then we hone their clinical skills by, the center has ongoing training specifically for our team. As I mentioned, we do our own motivational interviewing training that really kind of goes through what that looks like in this specific environment. And then they are housed together. So they're not working in their own individual bubbles. These folks are working together in either shared office space or right next door to each other. So there's a lot of learning that's happening in the moment from people who are doing the work, have been doing it, and then teaching other people, both by modeling and giving feedback. We can also monitor phone calls and kind of walk people through that for in the moment training. Hey, here's some options, here's how to handle that. So it's kind of a mix. We don't have like a really super formal training, but we have a whole lot of documents. We write everything down. Everything's a workflow or a one sheet, as you saw. We track everything.
That's wonderful. Well, thank you so much. We'll get to more questions at the end after we hear from Kaysie and Jackie, but I think this has been a great presentation, and Mindy Clouden and others had referenced the work that you guys were doing, and so this is a really nice complement to the series, so this is great. So thank you so much, and so we're going to punt to Jackie and to Kaysie to talk a bit about the work that's happening in the Eastern Rural Plains. And I had to give Jackie a hard time from those of us who are from Eastern Colorado. I told her that I thought Lamar looked like it changed a lot based on her screen. But then we actually looked closer at Kaysie's and we realized, yes, that's actually more like Eastern Colorado. So it's awesome to have both Jackie and Kaysie on. As a rural Plains native myself, it's always good to have folks from our urban communities as well as our rural community share some of the perspectives. So Jackie and Kaysie, we'll turn it over to you.
Thank you for having us. Can you hear me okay?
Beautifully.
Okay, good. The reason there are two of us on is that I'm actually retiring a week from Friday, and Kaysie was coming on, and I thought it was a perfect ending to my position and Kaysie coming on, because we both go way back. We both worked in public health for years, and we've been involved with the navigation program since we started it down here in 2012 when we got a CMS grant. That's when I came to work for Southeast Health Group from public health, and I had worked in public health for almost 30 years and served on the board for Southeast Health Group for about 27 years. And so it was just perfect timing and a perfect opportunity for me to bring what I knew to the table. And we were fortunate enough to recruit Kaysie to take my place. And I'm going to let her talk a little bit about herself and tell you what she's been doing the last few years. And we, again, appreciate you inviting us. And I think it's a great contrast to show our rural frontier compared to the urban areas.
Thanks, Jackie. Thanks, Andy, for having me as well. And I'm excited to be joining Southeast Health Group just a couple weeks in here, and thankful to be able to have Jackie with me as we make this transition. So my background prior to coming to Southeast, I was in public health for over a decade, worked at Otero County Health Department, and was also the executive director at Benton County Public Health before I left and went to Otero Junior College, specifically working under a subcontract through Southeast on patient navigation, community health worker training. So you guys able to see my screen and my slides?
Yep, looks good to me.
Yep, all good, Kaysie.
All right, so just to give you a little bit more context about where Southeast Health Group, who we serve. So we are a community mental health center that does lots of other things besides that, and we'll talk a little bit more about that. But we are in the southeast corner of the state. We do serve a 6-county region. We have both rural counties and frontier counties. We have a lot of square miles, almost 10,000 square miles in our 6-county service area. We have about 48,000 residents. And to quote our CEO, JC Karika, I don't know if this is an accurate census data, but 350,000 cows. You can see a few behind me. So there's more cows than people, but that's how some of us like it. We are have a high Medicaid population. We have grown a lot, and we'll talk a little bit more about all the different services that Southeast does, but we're up to 160 staff serving that 6-county region. And we do have 15 different locations within that 6 counties doing a myriad of things. You'll see we offer lots of different types of services. One thing about our community, our region, we tend to be poorer, less educated, and have a higher incidence of chronic disease than other areas in Colorado. So again, we don't just do mental health, we do also substance abuse, use disorder. We also have lots of different physical health programs, including primary care that was integrated within Southeast. We have a wellness center. We do health navigation / care coordination. We also have a wonderful peer assistance program, and we also do physical therapy. So give you a little bit of a background on the Navigator program here at Southeast and kind of some of the bigger context that it falls within. As most of you are probably aware, HCPF, Healthcare Policy and Financing, and their Colorado Medicaid started going through an Accountable Care Collaborative project back in 2011. And it started with RICOs and behavioral health organizations that were doing that. And that model really went until 2018. And that was when they first got into trying to see how we could coordinate with Medicaid members and those specifically connecting them to primary care. And the goal of those were to start looking at how we avoid long-term chronic conditions, and obviously try to reduce the cost to the state Medicaid budget. So back in 2012, Southeast Health Group recognized that we had a definitely high Medicaid costs in our region of the state. In particular, in Prowers County, which is one of the counties, there were over 61% of the funds, Medicaid funds, were being used by just 3% of the Medicaid members. And so at that time, in order to try to address that problem, Southeast reached out and received a Health Innovations Award from the Centers for Medicare and Medicaid, and really launched an innovative program into doing health navigation. At that time, they hired 6 health navigators that worked specifically just in Prowers County to try to address this issue. They collaborated with the federally qualified healthcare centers, High Plains in Lamar, as well as the Prowers Medical Center, which is the hospital. And Otero Junior College was brought on as a subcontractor to work on training. So in 2012 and 13, Otero Junior College developed a health navigation overview course that trained incumbent workers at those facilities, partner facilities, as well as the 6 new health navigators. As part of that subcontract, Otero then developed out a community health worker certificate that started in 2013. It was a 1-year 30-credit certificate, and that is still in place today. And then the health, they also developed a 2-year health navigator associate degree. So trying to build out a formalized education system so that those that got into this and maybe didn't have education prior could build a career path. And in our region of the state, we struggle to find providers. And so we are trying to find individuals that can help us with navigation and also to build their skills. So that project was very successful. It showed that we were able to decrease costs among those Medicaid members that had navigation services. And so at that time, when the CMS grant went away, the organization decided to go ahead and keep navigation and actually expand it. So they were funding it, so they kept 4 navigators, but expanded the service area to all 6 of our counties in 2015. At that time, again, Otero Junior College went and received funds from the state health department to continue to explore workforce development options. And so that is currently in place, and they're still doing those pieces. Back in 2018, there was really phase 2 of the ACC, and Health Colorado, Inc. is the region that we are a part of in the RAISE, and I'll talk a little bit more about how that affects the work that we do. And then I just wanted to also highlight that the work continued through Otero Junior College, and in 2019, they articulated their associate degree with a bachelor's in lifestyle medicine with Metro State out of Denver, so that again, navigators that were wanting to get further education had a career path to do that. So we're going to focus a lot, as Kristen mentioned, Medicaid is a big, the main funder of navigation or care coordination. We also, just like she said, we'll do it for other insurances, but I just wanted to provide kind of a framework of how that works within our organization. And so you'll see Health First Colorado, which is basically Colorado Medicaid, is the Accountable Care Collaborative. And then they break those down into different regions. We are in Region 4, which was contracted with Health Colorado, Inc. And so they're the region that we work with. They actually serve 19 counties within that region. So a regional care collaborative, regional accountable entity array for ours, again, is Health Colorado, which is based out of Pueblo. And it has one FQHC, which is valley-wide, and then other community mental health centers. So Health Solutions, San Luis Valley Behavioral Health, Sol Vista Health, and Southeast Health, us, are partners and actually stakeholders in that RAY. Beacon Health Options is also the administrator for the RAY. So our region is similar to our region that Southeast serves, but we've got a high percentage of members on Medicaid. 32, almost 30, a little over 31% are on Medicaid. That's the highest of all the RAYs. So the other RAYs have a range of 18 to 24% of their population on Medicaid. And again, large poverty area within our 19 county region, and very diverse. And so for those that may not work with this system, I just wanted to show a little bit about how that money and those payments come and how that changed from phase 1 to phase 2. So HCPF sends the money for per member per month payments to the RAY, and then the RAY then pays those to primary care, where HCPF sends fee-for-service payments directly to primary care. As far as the behavioral health side, though, they still use a capitated payment system, but that goes to the RAY, and then the RAY does a fee-for-service or other arrangement to the behavioral health services in the region. I didn't mention when I had the last slide on, but I should have, that those stakeholders that I listed for RAY are not the only providers in the region, obviously, and so the RAY works with contracting out for other providers to serve that as well. So back to Health Navigators. Why Health Navigators are important when we're looking at Medicaid is we know that really Health Navigators do help achieve IHI's triple aim. So improving patient care and satisfaction, decreasing cost, and improving population health. And this really was shown when Southeast did our project, the Tipping Point project with CMS. We found those results, and Medicaid has found those results with phase 1, that this is the case as well. So from Health Colorado, which again is our RAY, we are working under our navigators and care coordinators are helping to work with this population health pyramid. And so we're looking at this particular graphic. I know is a little bit hard to see, but it shows the number of members and how they break down into different segments. So we have complex care management and different subpopulations within them. We have different conditions management that our navigators work on, where it's looking at different specific conditions, whether it be hypertension or diabetes. And then we also have prevention support and resources. So this is where we're really looking at those population health measures such as well care, also the social determinants of health like food security, and trying to see how we can serve our members in each of those and bring down the costs and increase patients' health. Related to that, just our navigators are working with different performance indicators with the members that they're trying to impact. And so I thought this might be helpful to kind of get an idea of some of the things that they're working on with our members. So of course, behavioral health is what is our bread and butter here at Southeast, but we do so many other things. But navigators are definitely working to increase engagement in behavioral health. So one of the goals is to try to get our members to have at least one behavioral health service within the last 12 months. Of course, we want members to have preventative care like dental visits and well child. From a prenatal standpoint, we want at least pregnant women to have at least one prenatal visit with before she delivers. We're trying to get those ER overutilization under control. So we do activities there. Under the health neighborhoods, this is where we look at what kind of things are going on in our communities, what kind of referrals are happening between specialty care and primary care, and potentially having care compacts for those. And then again, trying to look at how we bring down potentially avoidable costs. And then there are behavioral health specific incentives that we're looking at as well. So how do we engage our members in outpatient substance use? So if they've recently had a diagnosis, how do we continue? Maybe they've had one, but we know it might take more than one. So how do we foster that? Following up with individuals after they've had an inpatient hospital discharge for mental health, so trying to make sure they're seen in an outpatient setting within 7 days. Following up within 7 days after an emergency department visit if somebody's been in the ER for a substance use disorder. Trying to screen for positive depression, but then also if it's not enough to screen, we have to get them connected to services as well. So connecting them to mental health services within 30 days after they have a positive depression screen. And then also looking at other behavioral health screenings and assessments for those in foster care. And if we have those that are a part of our array, we're really trying to reach out and get them within to connect them to services. So again, our navigators are a little bit different than what Kristen discussed. Our navigators, we have 4 health navigators. We do have 1 master's level navigator. We have 1 bachelor's navigator, and we have 2 navigators that have high school degrees, but they've gone through the Patient Navigator Training Collaborative and received training there. We also have added 3 RNs, which are great additions to our team. We've got 2 bachelor's level RNs and 2 bachelor's level nurses and 1 RN, and they are also able to help us do some additional things. The navigators, as Kristen mentioned, our navigators do a lot of work, obviously, on the phone, especially now, or on the computer, iPads with COVID. But we do have navigators that will, when we're not in a COVID situation, be doing other things like going with transportation. We'll have navigators and our nurses that may be doing home visits to try to connect with clients that they're having difficulty reaching. So again, our navigators are really a part of that integrated team that we have here at Southeast. We're trying to make sure the patient gets the right care at the right place at the right time. They really work on navigating all those complex systems, whether it be healthcare, behavioral health, work with human services, public health, and even insurance, really trying to reduce our clients' barriers to care. And again, those could be things like transportation or childcare that might be affecting somebody getting to their appointments. They also coordinate care. This is both internally. So again, we have a lot of these services here through Southeast, but also with other health providers within our county or within our region. And then also referring to community resources. So food, employment, education, housing, all are very important there. One thing we always try to focus on when we're working with clients is how, just trying to keep this in the back of our mind is how does this interlay with the social determinants of health, and how do we try to impact that along all of these different layers. Jackie, do you want to talk a little bit about our couple's client success stories?
I will. Just for a little background here, during our CMS project, our 3-year CMS project, we had a great person that worked with us, and she really honed in on us keeping our success stories and stories about different things that the navigators encountered. And so we have a lot of really great stories, but I'm just going to tell you a couple because they were the ones that kind of really made me happy. We've had several patients that the navigators have helped that have had a cancer diagnosis, and transportation is one of our biggest problems. We're in the rural area, and so if anybody has to go for chemo or radiation, they have to go, the closest place is Pueblo. And the navigators have worked with a couple of really sad cases that people didn't have any family, didn't have any resources, didn't have any way to get there. And the navigators managed the clients getting there. They arranged for temporary housing. They were able to keep housing here. They got them up there every day for 6 weeks for radiation. And it was really a testament to how well the navigators could put things together. And both of those clients, one was a long-term mentally ill client that has been in and out of the system. And she was so happy that we helped her to get through that. The other one was a veteran, and he told me when I talked to him, he said, honey, I couldn't have done it without these gals. And so, I mean, just that really thankful opportunity for us to help people. The other great story we had is we had a lady that was in her 40s come here to Prowers County. She was homeless, and she came here from another state to stay with her sister because she was homeless and she was on substances, and she thought that that would give her a chance. She didn't make it with her sister. They couldn't get along, and so she was going to be homeless again. Our Navigators intervened, and they helped her get in to Southeast Health Group for substance abuse treatment, got her into primary care at High Plains Clinic, helped her find a place to live, subsidized housing, got her that assistance for her. And eventually she got a job and she worked, and she wrote us the best letter that said that she had, in her life, never had anybody help her like that, and that she was confident she could go forward and live a good life. And she still is here, and she is doing very well. So just a few little nuggets of good stories, but there's been a lot more, and it's due to our Navigators work.
Right. So another quick story I wanted to share. Let me get my screen to cooperate. So this particular client is someone that I had the pleasure of getting to know when I was at my time at Otero Junior College. This picture and this story I'm sharing with permission from Izzy Harris, who I'm going to talk about. So this is Izzy. He was homeless prior to this. This is on day one of his sobriety. This picture was taken. He arrived at the newly opened Fort Lyon Supportive Residential Community. So this was several years ago, back in 2012. The Fort Lyon is in our region. It's down in Benton County, and it provides recovery-oriented transitional housing to homeless individuals. And Fort Lyon is operated by the Colorado Coalition for the Homeless. Prior to Fort Lyon, Izzy was homeless, living on the side of the South Platte River in Denver, really in the grips of alcoholism. As he says, after failed marriages, hurt family, jails, prison, and a nearly fatal stabbing and alcohol withdrawal-induced seizures, he finally realized he didn't have the strength to do it alone. So Otero Junior College, because of our partnership with Southeast Health Group, partnered with the Colorado Coalition for the Homeless to offer courses actually at Fort Lyon. That's where I met Izzy. Izzy was among the first group of students to enroll on our newly created Community Health Worker Certificate. And after 2 successful semesters in that program and at Fort Lyon, he continued his courses at OJC on our main campus in La Junta, and he chose this program because he's passionate about helping other people. This particular picture is here. Izzy's there on the left. This is what on his field experience placement sites at the Otero County Health Department doing outreach. This is move-in day. This was for the first time in 6 years, Izzy had a place to call his own. He referred to his apartment in La Junta as his stress-free zone. The following November, after he moved into his apartment, Izzy made a trip back to Denver to do a gratitude tour. He visited and thanked the workers that were at the shelters, at the soup kitchens, the clinics, and the hospitals, thanking them for not giving up on him. He returned to the site of his old spot on the river, which is where the picture he gave me comes from, and he collected stones by where he used to sleep. The stones are now in a fountain that he keeps in his home as a reminder for where he started and how far he's come. And Izzy's neighbor on the river also went through our program, and he, after also graduated from our program, and went on and worked at Fort Lyon, and just recently retired from there. And then this last picture here is Izzy on the day he received his Health Navigator Associate of Applied Science degree, and was also one of our commencement speakers for our graduation ceremony. And he continues to live out his motto of every day is about doing the next right thing. And he's finishing up his bachelor's degree at CSU Pueblo. So we're really proud of Izzy, and he's a neat part of our story for sure. So at this time, I'd like to take any questions, or if we want to hold those to the end.
I think this is great, and Jackie and Kaysie and Kristen will have you come on as well, but this is dynamite. I love that you guys ended out with some stories and talking about the, talking about the successes. And I think Kaysie and Jackie, what I also heard too, in that I think through the lens of the success stories are a lot of fantastic partnerships. So it does sound like really the strong sense with your FQHC, the mental health center, your education community, and then the networks, like it really looks like it's working famously in terms of how you guys are all engaging. So congratulations. I think that's super amazing. Erin, I want to just be respectful. Do we see anything in the chat right now for questions? Because I definitely have a few building off of what Kaysie and Jackie had shared. Are we good?
Yeah, we're good. But please, anyone, if you want to take an opportunity to type any questions there, we will love to hear from you.
Okay, good. So Jackie and Kaysie, I think building off, some of the questions that I asked Kristen as well, but I think specifically, ladies, in terms of that background and training, and to the extent, are the folks, and if you can remind us, are the people who are also serving in the navigator role, are they licensed or are they lay, or is it a mix as well?
This is Jackie, and I'll speak to that. None of our navigators are licensed. Like Kaysie said, we have one navigator that has a master's degree and one with a bachelor's degree. And of course, they bill, just like Kristen said, under the codes and things that Medicaid has. But additionally, the two navigators that we have, that one has an associate's degree and the other one doesn't quite have that, but they both have went through the training and have the navigator certification. They bill as peers. They went through peer training and they are what we call peers, but they're in the navigation program. So that's how we do that. I would have to say I love that Kristen has all of those wonderful licensed people and the social workers, and we have a tough time down here even hiring. I mean, we've got openings now and it's just getting tougher all the time for our therapists and clinicians, and but that we do a good job with what we have, and we provide training. They all go to motivational interviewing. We provide that along with many other trainings that are required for the navigation positions.
That's awesome. Well, congratulations. And I was wondering a little bit, and I heard the different iterations, but it does sound like that peer around, and the peer, is that specifically around drug and alcohol? Is that the peer approach?
It's under the Medicaid. I don't necessarily think it's under just substance abuse. We have a fantastic billing and business operations that work hand in hand with meeting the requirements. And we have like Kaysie pointed out, we have a big peer staff as well. And so we do a lot of peer work with our peers, and have the two navigators that are also credentialed as peers.
Great. And I think so many people have been really wondering about how to sustain this work and the billing components. So I do love that you and you ladies and Kristen have all talked about those strategies. Let me just ask you guys, so for the areas where you might not be able to bill for those visits or peer visits or under Medicaid or private insurance, are you also subsidizing your work through any grants as well, or are you able to basically use the standard insurance payments to help really keep your navigation work at large supported?
Well, we're like Kristen too. We see everybody. We don't. We work with a lot of people that don't have coverage, and we are a CAS site as well, so we can help people get on Medicaid, and the Navigators will help with that. And so we do try to get people in services and on Medicaid if they're eligible for that. What we've been able to do is we've had a few grants. We had the CMS grant for 3 years, and then it was so successful to our overall work that we decided that we had to continue it only for the 6 counties. We did reduce the staff numbers down, and it's kind of fluctuated here and there, you know, as people get promotions or leave. But we've been pretty consistent with the 4 Navigators for probably the last year. So, but we've been able to under the accountable care, under the RAY, for care coordination, we do receive some funding for that, but you have to meet those incentives, you know, the goals for those things. And there's all kinds of formulas and different things. And thankfully we have a great CEO who is pretty sharp and adept, and he is at the table all the time, making sure that things are fair and done right.
That's great, and I think a strong sense of leadership, really, and people who are committed this way, it's key. So Kaysie, I'm interested because I think you have done a fantastic job in your career of really thinking about the capacity building for navigation, the training in the area. So I think as you're transitioning into this role with and Jackie retiring, but hopefully staying in the mix, I guess, Kaysie, as you're sort of thinking about this opportunity and for CHWs and Navigators, I guess what advice, 2 things, I think, what are you thinking about the opportunity for Navigators as you're speaking to the community at large today, you know, with the work you've done and then the role you're coming into now, and then ultimately, what advice would you give folks who might be considering doing a program like this? What's coming up for you kind of in that sort of general area?
Andy, are you referring specifically to around kind of education and training opportunities?
Yeah, just whatever, education, training, I think that's part of it, you know, just building capacity. And then in terms of the work that you see that you're, you know, in the work you're doing ahead, and that you have that background of capacity building and training and support of navigation, if there's any sort of really big things that you think are good opportunities for people to look for, or things you're thinking of, and then what advice would you give folks, as you and Jackie, and I would ask the same of Kristen, what advice would you give for folks who are thinking about moving in the direction of setting up programming like you're doing? But Kaysie, really interested from your perspective, because I think you've had a great path with training and education around CHW and PN work.
Thanks. I think there's, as usual, there's lots of different pieces as far as training and education. I'm in our state, people have different options to do the Patient Navigator Training Collaborative, which has a long history of providing wonderful courses, continuing education type courses. So that's a great option. I know, like I said, our 2 navigators that we have employed right now that don't have bachelor's or higher level degrees have gone through those trainings. And if individuals aren't familiar with the assessment and registry, the Colorado Workforce Development Initiative, I have a link on my reference slide that'll be coming up that you can get to that. I think that's great. I think those programs, as with our Health Navigator programs, always struggle with sustainability, I think, even, and then just changing. It'll be interesting to see what continues to be funded and the focus at the state on these different programs. I know at Otero Junior College, we've invested we had invested a lot of time and effort in programming, but it's always hard in our small rural areas to get the numbers we need to build sustainable programs. And so, you know, if individuals, I think individuals, depending on where they're at with their education, if they're looking at a shorter term training, or they already have advanced education, then I think Patient Navigator Training Collaborative is a wonderful option. If individuals are maybe wanting to have something that will count towards a degree at some point and want to maybe be able to come in and out of training, some of the programming that Otero Junior College is set up, where you can get a certificate, associate, bachelor's, and then on is a great option. I think it highlights just the differences between rural and urban, but everybody kind of struggles with how we're going to pay for these programs, and just getting creative on how we can do that and still serve our clients. I don't have any big aha moments, unfortunately, on that yet, but
I think, you know, what you guys have even mentioned already about there is case billing and that you've come in. I think there's some folks that are only grant supported. And so I think that around the mental health, behavioral, and substance issues, that there's actually some great resources and some things that you've already set up that I think can somewhat for care management and case management and care coordination have been really good models to consider for the work. So I think this is outstanding that you mentioned it. And I want to just go to a note that Mindy had noted. Mindy Clouden had said that there's also a peer specialist training program in Colorado by the Mental Wellness Network. And Mindy provided that link, so we'll add that in the chat. So I think this is great, because I think we've learned of several different training approaches, whether they're certificates or, you know, for your toolbox in really growing your skill set, as well as pieces that can be helpful as certifications and possible credential that can build into additional components. And I think, like you were talking, Kaysie, even that associate degree building out for people for bachelor level work, if that's the course in the ladder of workforce development, there's some great things. And then of course with PNTC, and we've talked about the resources available. And that workforce development component, I think, will be good for our state. It's just, how does that buckle into some real huge reimbursement too? So I know we're all having an eye towards that. Kristen, let me ask you as well. I think one of the things I'm curious for you, because I think, as Jackie noted, and you and I had talked about in the getting ready for this component, is ultimately, is there any sort of turf battle, particularly around folks who might not be graduate prepared or might not be licensed in this area? So people who have an associate's degree, or as you mentioned, people that are working in your team or bachelor, is there any pushback that, like, hey, you're not like credential, like you're not a graduate level work, you don't have a clinical license, should you be serving in the role? Have you encountered any of that, or what has that been like as you guys are engaging in your programming?
Not at all. And so we've been really fortunate. Like, I think the key that we've found is really kind of diversifying and not being afraid of taking on different things. And so, you know, we were able to prove through navigation that we could man a phone line really well and do good answer rates and all this stuff. And so then when the center said, hey, let's do centralized scheduling and have a main operator system that we've never had before, that actually came under our department. And so we worked really closely with those folks to cross-train on how do we take those incoming calls, how do we get people where they need to go with the fewest number of transfers and in this customer service. So we had a lot of experience of working with a broad range of education and degrees. I think there was a little bit of that, like in the beginning, I think being in a mental health center, of folks being like, why are you talking to my clients? What's this case manager doing here? But as soon as they saw that they're getting more support and more services, and we worked as a team, you know, we pretty quickly got through all that. So we haven't seen that. It's just different skill sets. And so, you know, the folks that are master's level, we can do some diversified billing there. Like if we notice that our case management isn't cutting it, we can have them do some individual services or some intakes, or, you know, we have some flexibility. And that's, you know, we've built in actually a whole level of care, which could be a whole different presentation, but where we noticed that there was a lot of clients only engaging in this navigation level of care. They were getting their meds and they were just calling us when they needed something quick in the moment, and they liked talking to us. And so we actually built out, and now we have about 4,000 clients assigned to navigation for their care coordination. So I think it's just looking for those opportunities. Where can you diversify? And then rolling up your sleeves, getting into the billing. I know it hurts our brains. Again, we just want to help people. We didn't get in this to like understand how Medicaid billing works, but we have to. And so things like, you know, less than 8-minute contacts don't get billed. So how do we increase the time, and how do we stay connected with people in creative ways? Are we using the wrong billing codes? When I started, we really unpacked a lot of that. We were using some lower billing codes where I was like, that's not what we're doing. Why don't we switch over to this code? And so I think it's really kind of being willing to try different things, get creative as new projects and opportunities, and then getting out there in the community, even if it's not billed, us being there in community events, doing presentations like this, sitting at a resource booth, you know, whatever's going on, just kind of participating and being there is going to help drum up those contacts and drum up business and ultimately help people, which is our goal. So yeah, I think it's been a lesson in creativity, and we've been fortunate enough, again, to have those opportunities in a big mental health system where we can kind of take on some of those other tasks and teams that can offset some of those deficits.
Awesome, thank you. And I don't know about everyone else working at home, but I feel like I'm just now moving between places that are quiet and less quiet. So I thought I was in a quasi-quiet spot, so I will try to be quick as we wrap up here. So ladies, I think this has been a dynamite panel and series. I guess as we close out, Erin, we don't have anybody on the phone solely today, right? Okay.
No.
Okay, this is the last call for questions. I know we've gotten some notes about needing to see this series recorded on the PNTC site. Maybe not be able to see everybody today, but just a reminder, if you missed anything on the PNT site, today's webinar, as well as all of the others, are housed at that spot. So my other question, I think, as we're rounding out, I guess, Kristen and Kaysie and Jackie, just any specific piece of advice you would give our folks attending today about really integration of this type of program, where to start, what to avoid, any sort of last final words of wisdom, and we'll wrap up today. So Kristen, I'll start with you.
Yeah, I mean, I think it's really kind of about seeing it as an opportunity to do creative, exciting, innovative behavioral health and really population health work. And that's what gets me jazzed. That's what gets me up every morning. That's what, you know, makes people want to come and work for this team and this program. And so really kind of seeing it as an opportunity and as an opportunity to help a whole bunch of people. And so really kind of keeping that positive focus helps us keep that customer service lens. So if you can kind of start from that point of having that really clear vision and understanding, and having the folks who can implement that and model that and keep that going, you're going to be super successful. And for us, we found that you get some newbie folks right out of, whether it's grad school or, you know, college, or get some newbies in there who are excited and raring to go, and you know, you're going to have a dynamite team. So it's really fun work. It's really rewarding. I think everybody should do it. My takeaway.
Everybody should do it. All right, good. Yeah, we might be preaching to the choir, but I love it. So that's great. And Jackie and Kaysie, I love to say that I love this umbrella, your logo. I think it's awesome, and it always does make it think about the sort of canopy of care and what's happening in the community, which I think you guys really told that story. So Kaysie, I guess any final words of wisdom, and then Jackie, since it's almost the retirement phase, we're going to leave you with sage wisdom to bring us home. So Kaysie, anything else coming up for you?
I would just echo what Kristen said. I know that was one of the reasons that I was really excited about moving over to this position, as much as I loved my position at Otero Junior College, but getting back in the field, working with people, really seeing the direct impact with clients, and then just the integration between behavioral health and primary care and substance abuse and the social determinants of health. And of course, the population health is, you know, my background. And so I'm really passionate about that. I'm really passionate about, you know, trying to get rid of the health inequities that are within our region, which we have a lot. So I'm very passionate about that, and think that this work is really, really the future of how we can do all of the triple aims, like I said before, and increase patients' health and decrease costs. And so I'm excited about it. Thanks for having me.
And I'm glad that you did mention the triple aim again, and thinking about how do you connect the work to some of the accreditation and some of the measures as well, which I think in its own right is sort of its own form of reimbursement sustainability and making the case. So I really do love that component too. So thank you so much. Erin, just quickly before we go to Jackie, we are going to be doing an evaluation. Do you want to just share that in the, share some background, and then we'll have Jackie give us our final statement?
Sure. So as soon as we exit out of the webinar, you'll have an evaluation pop up. Should take less than a minute, and we really appreciate your feedback on that. And I'll send a follow-up email with the direct link to all the recordings so you can check those out. And you'll also be able to download the presenter's slides there as well.
Perfect. And I love that we have the resources here, and we'll share some of those that were coming through as well. I just have to say, when we were starting the Community Health Worker Patient Navigator Promotor de Salud Alliance, Jackie was one of the folks that reached out from a rural community, and I was really excited that we had someone coming in from mental and behavioral health, and has been, I think, following along, working with us. And I know that we've been sort of a grassroots effort and we're growing, but I want to thank Jackie for really being engaged, gave some really interesting and good insight for us to begin. And so it's awesome that we have her in this webinar. And then Jackie, I guess I would just say thank you for all of the work that you've done with us. And I guess if there's any way for you to continue on, we'd love it, but excited about Kaysie, of course, continuing the legacy. So I guess, Jackie, as you're rounding out and kind of going into a retirement, what's some final words of wisdom or advice for those of us who are still moving and grooving and working in this programming area?
Well, I think, you know, I come from a public health background, and I really believe in primary care, and I believe that Navigators are a key piece of that. And I think Kristen mentioned it, that, you know, we can finance all the crisis care, but we really aren't doing the best job with the preventative care, and it's harder to sell when you're asking for money. But, you know, that was my, when I was invited to join Southeast Health Group and be part of this, that was really why I decided to do it, because I thought, you know, what better opportunity on my last few years working with populations in Southeast Colorado to really be able to impact the care, the resources, the healthcare outcomes. And thankfully, it was a great opportunity, and I've seen it grow, and I've seen the work that the Navigators do. One of the things I've always noticed, and our staff loves our Navigators. I mean, the Navigators get requests every day, probably multiple requests. Can you help this person with this? Or, you know, can you talk to this person? Or, you know, can you do this? And not only do they get that from internally, but we have so many connections on the outside that they get called from our partners that have interfaced with us. And I think that what Southeast Health Group has done, and this isn't me, I mean, this was a vision that Becky Ottoman and JC and Nancy King had when they put the CMS grant together, and the board was very supportive of it, was that we had to do more, and we had to get away from the crisis care and try to figure out how to build the resources and to give people the best soil. You know, I always go back to, you can't grow bad flowers or good flowers in bad dirt, and you can't grow healthy people without some environmental changes, and trying to figure out what they need to be successful. And the Navigators do that, and they're that link. And I believe that our agency believes in team care and integrated care, and you know, that's what should continue. And I hope someday that the people that dole out the money will figure out that prevention is the best way to go, and that we'll save money by doing it. So I'll keep working on that, and I'll vote for people that I know will do that.
Oh, I thought you said you were going to run for governor.
I used to think I would do county commissioner, but then the last 3 years I was in public health, I didn't have the best commissioners, and I decided I didn't think I would probably do that. So
Well, I just have to say, I think anybody who has a mind for it, voting for it, moving for it, advocating, and sitting in those roles are key. So, Jackie, all I heard was this is part of a close, but there's some new openings, so we might consider it. But thank you guys a million, and I want to say thank you to all of you for putting in the great time. This series has been fantastic. I was really excited about rolling this out. A huge thank you for Mindy Clouden for representing and suggesting these panelists, and for Sarah, the several Sarahs who presented, Nick, and I think Lucille, Kristen, and we had several other folks that had been engaged in this work. So it's been fantastic to have such a dynamite group of people from all throughout the state. Just a quick note, the Patient Navigator Training Collaborative will be running basically the curriculum for level ones and several other sessions. In addition, I think Tai Chi, as well as happy hours for connected to navigation work and support in a supportive environment online are coming. And then I think we're working right now on some programming for resource base out of the 211 United Way and their support in COVID related initiatives, as well as their just overall support of resources throughout the state. We'll be sharing some perspective. And then there was a question and a request for case-based best practices learning in terms of the COVID-19 response in communities, as well as looking at just general community health navigation, supportive care in this period of time, and how different folks are working on workflows and the like. Erin, any other programming pieces that I mentioned that I didn't mention coming?
Nope, stay tuned. We've got lots of things coming. A few of the things Andy mentioned, we have registration live, so I'll link to those. And yeah, just stay tuned for further details on those webinars and opportunities that will be announced. We'd love to
Very good.
have you participate.
All right, so thanks ladies, Kaysie, Kristen, Jackie, so much for all of your support, and we will close out today. Thanks everybody, and have a good afternoon. And Erin, the evaluation is now coming. Boom,
Thank
right?
you. Bye.
Yes. Thank you all.
Thank you. Bye.
Have a good evening, afternoon.